Brian's welcome to the fifth in a series of webinars brought to you by the Association of Cancer Executives. In this session, the Seattle Cancer Care Alliance Infusion team will share several of the scheduling and staffing challenges they faced, stemming from the unique layout of their center and their solution for maintaining a balanced infusion workload across multiple staff, specialty, and spaces. The goals of the webinar today are to share learnings and guidance from our two speakers and to hear from webinar participants. As Brian mentioned, we will pause for questions. We will pause twice during the presentation. After each of our speakers finishes their section, we'll pause. And then at the end, we will have another opportunity, time permitting, for questions. One of the things we've learned from past seminars is that sometimes people hold back to submit their questions. So if you have a question, don't wait. Submit it as soon as possible so that we can ensure the speakers have the opportunity to respond. I'm pleased to introduce the speakers from SCCA and would like to thank Leantas for their sponsorship of this webinar. Our first speaker is going to be Angela Rodriguez. Angela is Associate Director of Clinical Operations at the Seattle Cancer Care Alliance, overseeing outpatient oncology infusion, clinical trials, acute evaluation, and hematology. She received her degree in nursing from the Winona State University and her master's degree in nursing from Hopkins, go Hopkins, in 2009. She's been a nurse for 15 years with experience in multiple specialties, focusing on operational leadership for the last 8 years. Rachel Dupree will be our second speaker. She works as a nursing supervisor in the infusion department at the SCCA. She also has experience as a hematology oncology nurse, an outpatient infusion nurse, and as a charge nurse. Rachel works closely with the infusion charge nurses to develop patient care assignments that are safe and optimize nursing care. Emily Kowalski could not join us today. However, we'll be in great hands with Angela and Rachel. And now I'd like to turn over the presentation to Angie.
Thank you, Nancy. Seattle Cancer Care Alliance is one of the only NCI-designated comprehensive cancer centers in the Pacific Northwest. It unites doctors from UW-Medicine, Fred Hutch Research Center, and Seattle Children's Hospital. This network and partnership is aligned to deliver high quality and high value care to our patients, which also includes making the most of our resources and our staff. Our main clinic is headquartered in South Lake Union. However, our inpatient hospital is in Seattle's University District up by the University of Washington campus. We do have an additional 5 community sites. There's one that is not shown here as it just started actually last month with us at Overlake. So that is another kind of eastern suburb of Seattle. Our infusion center here is actually split between multiple different floors. And so we have a total of 63 bays. This is a mixture of beds and chairs. And our rough patient volumes per day is about 140 to 160 Monday through Friday. And we're averaging about 80 to 100 Saturday, Sunday, and holidays. Our daily staffing is adjusted to our patient volumes, and so you do see a range here on the screen. Our goal is to have a ratio of 3 patients per 1 nurse at any given time, which at the end of the shift usually equates to about 6 to 8 patients per nurse per day. Our average length of stay per patient is between 2.5 and 3 hours per segment. However, we can have something as short as 5 minutes to something as long as 12 hours or more. Our main infusion center layout is the 5th floor here shown for you. We do have the additional 10 bays on our 4th floor. This area is dedicated to our shorter infusions of 2 hours and less. On our 5th floor unit, which you see, we have a lot of long hallways and very odd corners. This has potential of creating a patient safety issue for our nurses that might care for patients on multiple ends of the unit. Because of this, we created subspecialties, which you see in the different colors here. These subspecialties help limit the distance that nurses might need to go in caring for patients all at the same time. However, it also does mean that nurses, as well as our support staff, need to relocate themselves daily based on the purple flex room usage that you see here. These subspecialties also have potential of creating some unequitable workloads. Our blue area is our solid tumor area, where generally this is a very chemotherapy heavy area, where our pink area is more our bone marrow transplant and hematology, which is very heavy with hydration and blood products. And so they're much different demand on our nurses, which led to decreased staff satisfaction on our unit. We also have pretty unique scheduling practices. So we have decentralized scheduling here at SCCA. What this means is we have over 50 schedulers throughout our institution that can actually schedule into our unit at any given moment. Different departments also have different needs, where our solid tumor patients really like to plan out their day and months at a time and often schedule out a lot further, where our bone marrow transplant and the hematology patients need more urgent scheduling needs and are more frequently scheduling within about a week or two for their patients. And so what we did is we kind of mirrored our floor plan with different Epic templates to allow them to meet these different scheduling needs and not have capacity issues amongst each other or tying up opportune times for different patient population. Also, with the scheduling into subspecialties, there are times that this creates an issue with patient access or delays in under or overutilizing our space on each side. Patients may also have limited bays to book into, and so we might see schedules where there might be hours in between their provider visit in the morning or lab visit and their ability to get into our infusion area. What we have done to try to mitigate this is we've created a waitlist system. And so if there is a struggle with our many schedulers or things are not optimal for our patients, we'll have them put on a wait list where our internal infusion schedulers will work this wait list 24 to 48 hours prior to the appointments to try to optimize the time and decrease any waits for our patients. However, this actually does create some patient dissatisfaction because they don't really know their true schedule until a day or two prior to coming to see us. So here you can see these scheduling practices as well as our space utilization. So that pink area was our BMT and hematology area, where you see in the red where we're often over capacity into the actual allotted bays into that area. However, there are days where on our general oncology side, we have the capacity to absorb that. And so when we looked at this, we really wanted to say, okay, where we're under and overutilizing our space, how can we maybe combine this in a better way to help to optimize it in the future? So now I'm going to be handing off to Rachel here in just a minute to discuss our nursing assignments. We just want to pause and check in to see if there's anybody that has any questions at this moment.
So Angie, we have not had any questions come in yet. So we can go on to Rachel, but to all participating, please send your questions as soon as you have them. Thank you.
What you're seeing here is an example of an old RN assignment sheet. Previously, creating our nursing assignments was a manual process that couldn't be easily adapted to pull people to new initiatives. Making the schedule for the next day was a 4-hour plus process with multiple people creating the schedule and editing it. There was one handwritten original schedule for each side or subspecialty. Because of the way the assignments were done, we would have to flex rooms and keep nursing assignments overbooked. We were manually calculating nurses' acuity hours to ensure that assignments weren't too heavy and to see how many nurses we needed for each subspecialty side. We had to do this because we were staffing to the template and not to overbooking. A morning sick call involved erasing the entire column and then rewriting patient names, and then making new copies of the schedule for distribution. A lot of unnecessary work was required when we needed to make changes to the schedule throughout the day for things like cancellations, urgent add-ons, or late sick calls. The charge nurse had to alter their own copy and then walk to the station where the original was located to update it while notifying the RN of the change. They would then let our unit flow coordinator know so that they could update their copy, who would call the front desk to update their copy. They would then call, 4 separate schedules needed to be manually altered for each change to a patient's appointment. This was inefficient and there were multiple opportunities for communication breakdowns and errors. We knew something had to change with these inefficiencies. These were our initial goals. So we wanted to improve staff satisfaction by balancing nurse workloads, maintain and enhance patient safety by maintaining the co-location of RNs with their patients, maximize patient access by optimizing physical space and providing timely access to minimize patient delays. So then COVID hit, and that brought even more challenges. We needed to extend our hours of operation to 7 to 10, 7 days a week on our main unit, and we extended 2 extra hours in our short stay unit. We opened multiple new services to support our hospital decant. While we were planning to open an acute clinical evaluation clinic in July of this year, we needed to move that up to March. This clinic was conceptualized to assist our patients with acute symptoms and reduce the chance of them needing to be seen in the ER. This goal became even more important with the onset of COVID and worries that ERs in Seattle would be over capacity. New services like the COVID hotline and the testing centers required our triage and patient care expertise. There were increased staffing limitations because as an institution, we weren't allowing anyone to come in with any symptoms whatsoever. So if you were having acute allergy symptoms, you had to stay home. Anyone who was classified at risk had to stay home and was removed from patient care. With increasing needs for social distancing, we moved people to offsite locations or they transitioned to work from home if they were doing administrative tasks. With these limitations, we were also training and pulling our staff to support these new services. So the same goals that we had before were now more important than ever. We had to prioritize the asks of our staff, knowing that we're entering a time of rapid change and likely anxiety with the pandemic. We knew we were moving inpatient protocols outpatient, and we had to open new services. Things were also rapidly changing with COVID, requiring new PPE and new schedules. There were increased staffing limitations. Remember, we had no additional staffing, and the extension of hours meant that we were having to stretch existing staff. We asked ourselves, what problems do we try to solve now? What may need to wait? Is addressing the level loading important enough to address now? And how will it help us? We decided to move forward to help level acuity and to create more free time that can be allocated to patient care or other new services. How we needed to prepare our staff changed over the course of the year and the pandemic, and we expect it to continue to change. We started out with our infusion team being the response team to go to the patient wherever they were for testing, be it a clinic room or an infusion bay. As this pandemic grew, we had to expand with an institutional response. There needed to be a huge partnership with all teams, departments, and disciplines. Some of our initiatives included front door screening for symptoms. We stood up 2 testing centers, one that was walk up and in the clinic building and one that was drive up. We started a COVID triage hotline for anyone to call with questions from 8 a.m. to 10 p.m. daily. We were the first epicenter in the US for the pandemic, and we were even getting calls from Kentucky. There needed to be movement of inpatient protocols, including regimens like EPOC, AIM, Hyper-CVAD, and GCLAM. We needed to move those to the outpatient setting. This required us to prepare clinic and infusion staff with new knowledge and education around these protocols. We also opened the acute clinical evaluation unit to decant the ER. We knew during this time we needed to be agile and flexible, as we didn't know what additional changes were coming our way. We decided to implement the nurse allocation tool using IQ. So what you're seeing here is the IQ view when you're inputting the nurse names and their start and stop times. The department schedules still schedule into separate Epic templates, but IQ mixes or pools these appointments into one unit. Our RNs are divided into pods, so they are co-located with their patients, and transfusions and hydrations are mixed more evenly with heavier chemo regimens across the unit. Our flex rooms are no longer necessary, and our support staff has an even workload. So this is the Gantt view, or what IQ looks like after you run the RN allocation. So our nurse allocation in IQ reduced the time we were spending on our nursing assignments and allowed us to make real-time adjustments. It now takes 30 minutes or less to make the nursing assignment for the next day. Previously, it took 4 hours. The Gantt view helps visualize the nursing assignment throughout the day, and pass-offs can be easily identified. And this real-time data allows transparency and a more accurate grasp of the current status. So here's a reminder of what our layout looked before. This is what didn't work for us. You remember Angie talking about how it was divided between heme and gen-onc, and then we had those purple flex rooms there in the middle that weren't working so well either. So this shows how the pooling and Epic schedules, along with using IQ and altering our layout, allowed for greater utilization of space without us being over capacity. We lost those purple flex rooms, and the yellow down there is the addition of our ACE clinic. So this is another reminder of how we were often overbooked on one side and we had room on another because we were scheduling into subspecialties versus pooling it all together and breaking it apart. And this shows how pooling on the Epic schedules and IQ, along with altering our fuller plan, allowed us to use our space better and not go over capacity. So we decided we needed to engage with our staff more to figure out what other things we could do. So we used multiple modes of communication to ask them for ideas and ways that we could increase our efficiency. One suggestion was to move the daily schedule online. We were originally still attached to the idea of having printed copies of the schedule. So we were downloading the schedule from IQ into an Excel document and printing those to place at all the nursing stations. We then moved to uploading the downloaded copy of the schedule to Microsoft Teams so that it can be viewed by many people at one time. This eliminates the need for the charge RN to alter multiple copies of a paper schedule throughout the day, freeing them up to help in other ways. There are fewer opportunities for communication breakdowns, and the offsite staff are able to access the schedule if needed as well. And most importantly, the schedule is now only located in one central place. So I want to pause to see if anyone has any questions at this point before moving on to Angie so she can discuss the later impacts of COVID on our capacity and where we are at now.
We have 2 questions.
Okay.
The first question is, what are the hours and days of the week of your urgent clinic?
So our acute evaluation clinic actually mirrors the hours of operation of our infusion center. So it was open from 8 a.m. to 10 p.m. And I'll discuss, we later retracted that back, and currently it is 10 a.m. to 10 p.m. Monday through Friday, and 8 a.m. to 6 p.m. Saturday and Sunday.
So I think you just answered the next question, which was hours of operation in your regular infusion center, and do you operate on Saturdays?
Yes, we do operate on Saturdays from 8 to 6.
Do you operate on Sunday though?
We do from 8 to 6, and holidays are the same.
Thank you. That's, I think we can go on and see if we have some more questions when you finish up.
Okay. So like many organizations throughout the United States and around the world, we definitely seen later impacts of COVID on our operations. Here at SCCA, we've seen approximately a 20% decline in our infusion visits. However, some of this was intentional. Many of our clinics shut down to new patient appointments, as well as deferred new chemotherapy starts, because we didn't know how COVID-19 would impact our immunocompromised patients. We did continue to see those that were currently on treatment. However, the idea was to protect those that were not already immunocompromised and to delay what we could. So we erred on the side of caution initially during the first wave of COVID here in Seattle. Now, as we worked throughout the year, we knew that this was definitely not sustainable for us to keep deferring these visits. And we also knew COVID-19 was not going to be going away anytime soon. So this summer, our clinics began to open again to new patients, as well as enrollment in bone marrow transplant. And as you see on the right-hand side here, we were anticipating this, what we called post-COVID surge. So all the deferred volume before, or those that might have just delayed their chemotherapy starts, we anticipated that we were going to see something beyond what our capacity could handle as we've seen this surge back to the healthcare facility. However, we anticipated that for us to be able to see a lot of these new patient visits, it was going to take 8 to 10 weeks or more with our current capacity limitations. So what we decided to do from an institutional recovery plan was actually to look at how can we open more peak hour capacity, because we know our patients absolutely want to come during our peak hours. And here at Seattle Cancer Care Alliance, our peak hours are generally 10 a.m. to about 4 to 5 p.m. So what we did is we partnered with our clinics and opened up our new GI Care neighborhood, which is part physician clinics and part infusion within that same area to hopefully open up some more capacity. We also looked at where we had underutilized space and where we were underutilizing our staff. So when we first planned with COVID, we extended all of our hours to 7 a.m. to 10 p.m. every single day of the week. And so we looked at, okay, what hours are we really not seeing that many patients that we anticipated? Where can we cut this back? And so here you see, we delayed our opening of our ACE clinic from 8 a.m. to 10 a.m. because we really hardly seen any patients prior to 10 a.m. We also developed floating processes with our other infusion areas to try to make sure that if there was any sick calls, we can optimize our staffing to deliver high quality patient care and make sure our patient needs were met throughout the organization. We also shortened our short stay unit back to 8:30 to 6:30. We had previously extended those 2 extra hours in the evening, as well as shortened our weekend hours. We did implement a multi-departmental huddle in the morning and in the evening to help anticipate if there was any staffing needs for the next day or even patient needs in the evening if we would need to transfer as many units close at different times throughout the organization. Now, I will say this, our staff has been super resilient this year, and I'm sure many of you guys have seen that as well throughout your own organizations. We have found that our staff has also been incredibly flexible during this time. However, when COVID-19 first hit us, we thought, okay, this is going to maybe hopefully last a couple months and we'll be through this. And, I think all of us understand this is not really going away anytime soon. And we have to look at what is the long-term sustainability of our staff and the many asks that we put on them. And so we do regular check-ins with our staff and rounding. We also ask them for ongoing feedback about how things are going, how they are doing with floating to many different areas in support of these ongoing initiatives, and making sure that we're meeting them where they're at as well, giving them a break if they need a break, and also encouraging them to use some vacation time and personal time if they need to. As we all know, everybody's anxiety levels and stress levels have definitely been at an all-time high throughout this entire year. We will say that, our staff truly have been our greatest strength this year. They have been absolutely amazing with the feedback that they provided us and ongoing thought of, what else can we be doing to improve patient care, the processes, as well as being mindful financially of how we're doing and how we're operating. but the teamwork that they've also shown and their adaptability has truly been amazing. Now, with all of this in mind and kind of where we're at 6 months after, we were the first epicenter of the United States here, we're still maintaining our 3 original goals of maximizing our patient access and ensuring that any oncology patients are able to get timely care here at Seattle Cancer Care Alliance. We also want to make sure that we're maintaining and enhancing our patient safety. So we're always adapting our testing procedures and surveillance testing for certain populations to make sure that everybody is safe to be here. And we want to make sure we're limiting visitors as well during this time, just for limiting exposure, as well as, maintaining and improving our staff satisfaction, knowing where they're at. But most importantly, with the wave of this year and the roller coaster that it's been, we really are looking at what is and how can we be, sustainable long term. And this does mean, keeping in mind matching our operations and being flexible to our operations with our new patient demands, whether or not that being tightening or lengthening our hours of operation based on what we see this year. Also revising our patient scheduling and ensuring timely access for them. But most importantly, too, looking at, our financial sustainability and stewardship, keeping in mind, how do we kind of maintain the bottom line here in ensuring that we're doing the best that we can with the resources and the space that we have too. We still have maintained our inpatient protocols outpatient. We've actually found that our patients are actually preferring to remain outpatient. And, we've definitely flexed our staff in different ways to kind of help us keep being mindful of this. Now, thinking back on this year and all of the process improvements, we definitely have gained some pearls of wisdom.
So we initially thought that we should delay the nurse allocation tool rollout. We were worried that this change would be too much along with other pandemic-related challenges. However, we are glad we followed our gut instinct, as this has greatly assisted us during this crazy year and has given us more flexibility and time that can be directed at patient care instead of manual schedule making.
Not only were we able to achieve our original goals of better utilization and ensuring level loading of patient acuity for our nurses, but we were also able to save time with many efficiencies that were completed this year. This also set ourselves up for more flexible staffing and more flexible scheduling for any other unforeseen needs in the future, like changing our operating hours, our staffing models, as well as adjusting to just frequent volume changes as we're opening other units during this time. One of the other big things is, as well, this presentation was geared at, what we've done here in Infusion. I do want to call out that a lot of these changes were partnerships with everybody throughout our organization, even with front door screening. Our chief nursing officer was out at the front helping screen patients, and we really all came together. And I just want to acknowledge everybody here at SCCA partnering with kind of the craziness of this year and all of our changes as well and their impacts to other departments. We have a slogan here at Seattle Cancer Care Alliance of better together, and that just could not be more true than it has been this year. We wanted to relay our contact information as well to you guys if there is any additional questions or follow-up that you would like to do with any of us after this presentation is done.
So thank you. We did have another question, and I have 1 or 2 things I was hoping maybe you could speak to from your experience. The first question was, will this be recorded to view later? And the answer to that is yes, via the ACE members only section of the website of the organization and the ACE YouTube channel. Wanted to know if you mentioned, of course, limiting visitors within the facility, and we all know that most of our patients come with someone who sits with them or helps them get from the front door upstairs and takes them back out. And you mentioned initially your extension of hours at the beginning of the COVID outbreak. When you looked at staff time to be able to help patients get up, in, out, and back out, how did that impact your scheduling?
So one of the shifts that we did make is our nursing assistants actually used to courier the medications from pharmacy to the nursing units. So the nurses then would carry them basically from fixes to the patient rooms. What we did was we actually reallocated that courier work to pharmacy technicians and other couriers throughout the organization to free up more nursing assistants to help with any patient care needs on the unit themselves. So if patients needed more assistance getting up and going to the bathroom, or if they needed any assistance with food or beverages, we had more nursing assistant staff available to help them during this time. We did limit visitors. We did not exclude visitors. So we did ask that, one visitor be here with the patient at a maximum. And it was mainly just so we can help social distance. But we also do know that, especially in oncology care, having a caregiver with them is also very important to, our patients' mental health and, support system during this trying time.
Thank you. Another question that has come up, I think, on every one of our seminars is what you did about break rooms.
Yeah, so our facilities has been amazing on, one, we can't have any more in-person meetings. Everything has gone to Zoom or virtual for the most part, especially at this stage in the game. But all of our previous conference rooms have actually been made into staff break rooms at this point. So we have additional room for them to spread out and have those breaks. We also did move some providers off campus here in the clinic building into other buildings, which freed up some other office space. And we made them into quiet rooms. So if any of our staff needed to take a 10-minute break to take off their masks and or face shields for the day, and they just needed kind of one of those breaks, we have those that are reservable for our staff to use. And anybody can kind of reserve those rooms as well.
Thank you. Great thoughts. Don't know what's going on in Seattle, but wanted to know if in the planning work that you're doing, if you've had to make any adjustments related to distant learning for children of your staff. In other words, time at home.
So, for us here in Infusion, I would say yes and no. I mean, we're definitely working with our staff that need a little bit more flexible schedules to align with, maybe when they don't have additional support at home. And so, we try to work with them to help them with those daycare concerns and virtual school. I will say that many of our staff that have been able to be converted to work from home, like administrative staff, have been relocated to home to help support that. We do require our staff to have somebody there to assist with childcare, even if their children are too young, just in the sense of you're definitely not as efficient trying to work when you have little ones that also want your attention. So we try to balance giving them an option to work from home, but also realizing that that additional support is also needed for them to still be effective and productive for work.
Thank you. We've had another question come in. The statement is not necessarily a COVID-related question. However, do you have a triage type nurse that ensures the patient is chair ready for treatment? For example, blood draws, port access, IV access, etc.
So our patient flow is a little bit different. So we have a few different things in place. Our lab is staffed with LPNs and RNs as well as phlebotomists. So they will often access ports for us if the patient does have a port, or start IVs for many of our medications besides vesicants, and ensure access is done that way. Many of our patients also have central lines here just with the long-term care treatment that they need. So I would say much of that access is already solidified before they come to us. We do have a nurse that preps our schedule and reviews orders, ensuring that everything is ready to go. The patient had a lab appointment scheduled, their labs drawn, their orders are in, their orders are signed, everything is ready to go for today's treatment. That nurse, we call our chart review nurse. They're working about 2 hours or more ahead on the schedule every day and prep for a little bit for the next day. But we do have that in place just to try to expedite what we can for our patients as soon as they come here. Many of our patients do, I would say about 65% to 70% see their providers on the same day of coming to infusion. So many of them are linked. And some providers do prefer to sign orders when they're seeing the patient, which does have potential of delaying things if they forget. So that chart review nurse is really there also to help us catch and expedite those things to make sure any of those issues are resolved prior to the patient coming to infusion. We also do have a triage nurse that does after hours and weekend triage. So if patients have, it's more telephone triage. So if patients call with a concern or a symptom issue, our nurses will either bring them into our ACE clinic for evaluation, send them to the emergency department, or be able to resolve any issues over the phone. And so we welcome that as a method for our patients as well.
Have you had to deal with some of the large, not only large centers, but other centers have someone who inadvertently gets into the facility and is COVID positive?
So we have had patients that have decided to walk up the stairs in our garage and like bypass our screening. We have had the occasional one of those. However, we do have identifiers on people if they have been successfully screened at our front doors. So we do have white stickers that say I have been screened in whatever day of the week that it is. So often if a patient does happen to bypass, now we've locked down the stairwells from our garage, or at least unable to bypass anybody without them noticing since that event, but you know, if they check in at any of our front desks and they do not have a I've been screened sticker, our front desks can conduct that screening as well. Our COVID positive patients that are known to us, you know, I will say that our patients have been really great about alerting us if they've tested positive at another community center. But those that are known to us, you know, we will actually have them wait in their car, call us, have them escorted to whatever the last appointment is for the day, which is often a tiered infusion, and have all services brought to them in that one room. So basically, if they're just here for labs and their provider visit, they will go into a designated room in our clinic area, and all the services will go to them into that room. But they're escorted throughout the building, so we can ensure kind of the footprint of what has been potentially touched or contaminated, and making sure that we're limiting exposure to everybody else.
Last question, words of wisdom. As people in the United States look toward the fall and the potential for flu and COVID, are there any other things that you all are doing or thinking about that you haven't already addressed relative to going forward?
I would honestly say, you know, the fall here in Seattle, we always have a pretty bad respiratory season in the fall, and so we are anticipating if we do get the dual surge of flu and COVID, it'll most likely hit us sometime in October, and so we're definitely prepping for a lot of that. And while we, you know, may have kind of relaxed a little bit on testing guidelines this summer, we started kind of ramping up again, testing for more procedures this fall. You know, we did institute face shields and face protection for our staff during any patient interaction, not just those with COVID or droplet precautions, but all patient interactions, and as well as offering it to our front desk staff. Our infection prevention specialists that we have here, I would say, are completely on top of the CDC and WHO recommendations, as well as jointly partner with UW Medicine and Fred Hutch with the research that they're doing, as well as the practices that they're doing at their organization, so we can all align, making sure that, you know, if our patients go back and forth between facilities, that they're experiencing the same expectation from their end as well. So I will say, you know, we definitely are anticipating something to come towards us this fall. However, I think it, you know, it's a lot of the same stuff that we have been doing, just making sure that we remain diligent on wearing proper PPE, hand hygiene, ensuring that people stay home if they're sick, and also ensuring our staff stay home if they're sick or have any symptoms whatsoever, just to try to help protect everybody that we can.
Angie and Rachel, thank you so much for a very informative webinar. I would like to thank all the participants today. We're very glad to have you here and hope you can join us for our next webinar in September. We also want to emphasize that we welcome all of our members to submit webinar presentation proposals of their own. And again, Angela and Rachel have kindly agreed to respond to any follow-up questions or thoughts about the seminar. Again, thank you all, and we look forward to being with you again in September.